Welcome to part 3 of aging. This PowerPoint is going to focus on the mental changes that we see in the older adult. Cognitive changes are not a normal part of aging. If a person has cognitive changes, something is going on physiologically or structurally in the brain. Cognitive disorders may cause a disturbance in orientation, memory, intellect, judgment, or affect. Changes in orientation may be person, place, time, situation, and following commands. It may be all of them or only one of them that's affected by the cognitive disorder. Memory may be affected, either short-term or long-term memory or both. Intellect may be affected, but sometimes this isn't as easy to notice as first. Judgment may be affected many ways. They can have poor judgment with people, like falling victim to scammers, and they can have poor judgment with finance, like buying things they should not be buying or giving away all their money. Affect is the way that we express our emotions or feelings to others through physical expressions, hand gestures, voice tone, and other emotional signs such as laughter or tears. Individual affect fluctuates according to our emotional state. People with cognitive or psychological disorders may display variations in their affect. A restricted or constricted affect describes mild restriction in the range or intensity of displaying feelings. As the reduction in display of emotion becomes more severe, the term blunted affect may be applied. The absence of any exhibition of emotions is described as a flat affect, where the voice is very monotone, their face is expressionless, and the body is immobile. Labile affect describes emotional instability or dramatic mood swings. When the outward display of emotion is out of control for the situation, such as laughing while describing pain or sadness, the affect is termed inappropriate. There are 3 main cognitive disorders that affect the older adult: depression, delirium, and dementia. Each one is different and has different causes and interventions. And we're going to discuss each of these in this PowerPoint. The best way for nurses to determine any cognitive changes that are occurring is to assess the patient's mental status. This is already part of our general head-to-toe assessment, where we ask orientation and following commands, and we may pick up on some cognitive changes here, but sometimes our normal mental exam makes us want to dig a little deeper. This is when we may want to do a mini mental state exam. To do this, we ask questions to assess for orientation, which we may have already done in our head-to-toe assessment. Next, we're going to have them name an object that we point to. Then we're going to have them read something simple and have them do what it says, like close your eyes, for example. This data will help us get a better idea of how well their brain is functioning. Other things we may need to assess include family history of behavioral or cognitive changes, history of drug or alcohol abuse, and if there are any recent neurological impairments such as a stroke, head trauma, or a brain tumor. We should also assess their appearance and how well it seems that they're caring for themselves. Are their clothes clean or dirty? Are they clean, or is it obvious they haven't bathed in a while? If they're incontinent, have their briefs been changed, and what does their skin look like? All of this will help us understand if they have the mental capacity to care for themselves. As people age, so do the people around them. Friends and loved ones start to die, there's less socialization than there once was, and oftentimes older adults become isolated as they have to depend on others to get them place to place. All of this can cause mental health issues in the older adult. Nurses need to recognize these mental health changes, as failing to do so may cause misdiagnosis for another disease or may cause the older adult to spiral into a deep depression and even attempt suicide. The risk for suicide is increased for older adults because everyone around them is dying and they feel like a burden. So what do they have to live for? Depression is the most common mood disorder for older adults, affecting up to 25% of older adults, although this number may be low due to self-reporting. Many older adults do not exhibit the usual signs of depression that you'll learn about in Block 2, but rather they show more subtle signs like fatigue and diminished memory and weight gain or weight loss and substance disorders. It's not uncommon for older adults to have no reason to know what day it is. They don't have a job to go to, they have no plans to do stuff, so they just don't know, and that's totally normal. But if you have a conversation with them, they know everything else that's going on. They may know it's springtime, they know it's daytime. They may even know like, hey, it's April, but they may not know it's April 10th. Although we do not discuss mental health in Block 1, it's very important to understand that depression in the older adult can seem very similar to other cognitive changes we'll discuss. The only way we may be able to tell the difference is to assess and talk with our patients, get to know them and understand them, assess their mental state. Older adults with depression are going to know exactly what is going on around them, but they may tell you, hey, I don't have anybody. I'm alone, I'm lonely, and those may be the only cues we have to depression. Let's discuss our first mental health change that affects older adults, which is delirium. Delirium is an acute confused state that begins with disorientation. The key word here is acute, meaning it just started happening. This abrupt onset is the first indicator that something is wrong. This is a new problem for them. Delirium is frequent in the elderly and is also common in children with fevers. This acute confused state is characterized by changes in cognition, consciousness, and alterations in the sleep-wake cycles, and all of this can fluctuate during the day. They may be fine 1 minute and not fine the next. Up to 35% of older adults will develop delirium during a hospitalization, and the after effects can be severely detrimental, including irreversible brain damage and sometimes death. Nurses must recognize and treat delirium as fast as possible to stop these outcomes from occurring. The issue is, many nurses won't recognize the acute changes and assume it's dementia, which is a long, slow, progressive disease. So what can cause this acute change in our older adult patients? Well, a lot actually. It can be caused by side effects from medication, pain, electrolyte imbalances, malnutrition, cerebral hypoxia, hypoglycemia, stroke, infections like UTI or pneumonia, withdrawal from drugs or alcohol, lack of sleep, and we are very good about interrupting sleep, and changes in sensory and in combination with all of these things. So basically, what we're doing to care for them is causing the delirium. There are medications that are more well known for causing delirium, and when we give these medications to an older adult, we should watch for acute changes. These drugs include digoxin, narcotics, benzodiazepines, antihistamines, antihypertensives, and antidepressants. The majority of delirium cases are caused by medications. So what will our delirium patient look like? Well, they can look totally different. What we know for sure is that the changes will be acute. The person will have disturbances in their level of consciousness. They may be wide awake 1 minute and completely unresponsive the next. They may have difficulty sustaining attention, and their attention may shift to other things rapidly. Their speech may be rambling and incoherent. They'll be disoriented to time and place, and maybe even to themselves. They will not have recent memory. In fact, they will have zero memory of the entire situation. They may be very distracted by things which are not there. They may have hallucinations and see and hear and feel things that aren't there. This may cause them fear and anxiety, which activates their sympathetic nervous system and puts them into fight or flight mode. So they may fight and kick you. They may get tachycardic and diaphoretic, and their blood pressure may elevate dangerously. They'll try to get out of bed and get away from the things that are scaring them. This is an incredibly scary situation for us and for them. We cannot reason with them. They cannot stop what they're doing. But if we can recognize and stop the delirium, they won't have any memory of what happened. And oftentimes they're extremely embarrassed that they did everything we say they did because they literally have no idea. So how do I treat delirium? Well, the best way to treat it is to prevent it. Know which patients are at risk. Any acutely ill older adult. Screen them for risk factors, which is pretty much anything that can get them admitted to the hospital, honestly. The next prevention strategies are also treatments. Treat the cause of the delirium. If it's being caused by medications, stop them. If it's an infection, treat the infection. We also want to avoid transferring the person all over to the hospital as much as possible. We want to frequently reorient the person. We want to make sure their pain is controlled, preferably without narcotics. We want to make sure they are hydrated and fed and they have adequate sleep. If they have glasses or hearing aids, make sure they have those on. Make sure they have everything else they need close to them. And we want to make sure we assess the patient using whichever assessment tool our facility uses. I've always used the CAM, the Confusion Assess method, but it's not the only one out there. But assessment tools make it much easier for us to figure out that they're having delirium instead of something else occurring. Now we're going to switch gears to dementia. Dementia is a broad term for generalized decline in higher level brain functioning, such as reasoning, social, and occupational functioning, with eventual decline in the ability to perform even basic activities of daily living, such as toileting and eating. The key for dementia is this is gradual. It is not acute like delirium. The symptoms are subtle and progress slowly. Elderly depression or delirium is often mislabeled as dementia, but depression and dementia can coexist, and delirium and dementia are completely different. Delirium and dementia are almost opposites. The most common type of dementia is Alzheimer's disease, and it's about 70% of all dementia cases. The other 30% of dementia cases are classified by their cause, either degenerative, vascular, neoplastic, demyelinating, infectious, inflammatory, toxic, metabolic, and psychiatric. We're going to focus on the broad topic of dementia and then Alzheimer's disease. Diagnosing dementia is made based on clinical observation, history, physical exam, and neuropsychological testing. Definitive diagnosis requires biopsy or autopsy of the brain tissue. The goals for dementia treatment are going to depend on who we're focusing on, the patient or the caregiver. For the patient, we want to try to maintain cognitive and physical functioning for as long as possible. The longer they can keep doing things for themselves, the better, which means we may need to get physical therapy and occupational therapy help. We may also need to provide assistance with their personal care while allowing them to do as much as possible. We want the patient to remain safe and harm-free. This includes injuries from wandering away. We also want to make sure the patient feels safe and then we're not going to cause them fear. For the caregiver, we want to try to reduce their stress and help them maintain emotional and physical health. Caring for someone with dementia is a 24-hour-a-day job, and there may be days they get zero sleep. The only rest they may get is when a person is admitted to the hospital. Let's get a little bit more in depth with the common type of dementia, which is Alzheimer's disease. Alzheimer's disease is the 5th leading cause of death in older adults, and it affects half of those over 85 years old. It can affect people as young as 40, but it's uncommon before 65. It is also not a normal aging process, even though it's so prevalent. There are many theories about how Alzheimer's disease is caused and what the risk factors are, including genetic causes, environmental causes, head trauma, stress, and vascular abnormalities. There are 2 types of Alzheimer's disease: familiar or early onset, which is very rare, and sporadic or late onset, which is the most common form. Sadly, these progressive, irreversible, degenerative neurological diseases have no cure and no prevention. We do know that advanced age is a risk factor, as well as diabetes, smoking, and depression, but there's a lot of conflicting information out there. It's not 100% clear how Alzheimer's occurs, but they do know that there are specific neuropathological and biochemical changes that affect neurotransmission. The brain has neurofibrillary tangles, which are tangled masses of non-functioning neurons and plaques made of amyloid protein. These cause the brain to become damaged and shrink. Biochemical changes include decreases in the enzyme that produces acetylcholine, which neurons need for transmission. There are 5 A's of Alzheimer's disease. Anomia, which is the inability to remember names of common things. Amnesia, which is memory loss. Apraxia, which is the misuse of objects because they fail to identify them. Agnosia, which is the inability to recognize things that they could tell by using their senses, like knowing it's a cat by hearing it meow, or knowing it's an orange because it smells like an orange. And then there's aphasia, which is the inability to express thoughts. They have valid thoughts, but they can't physically say them. All while this is occurring, they have decreased judgment, concentration, and attention span. There are 4 stages of Alzheimer's disease. Each one has an expected amount of time it will last, but it's so person specific. Some people will go through all 4 stages quickly and die within a few years, and some will last a very long time. In the early stages of stage 1, there may be mild cognitive impairment with forgetfulness and some subtle memory loss. There may be small difficulties at work or social activities, but they continue to function normally because they can overcome the small changes that are occurring, like joking it off or blaming it on something else. They may deny anything is wrong and avoid questions about memory issues. They may even have confabulation, which is making up stories or answers to maintain self-esteem. It's very different than lying. They're not trying to deceive the person they're talking to, but they're making up stories to compensate for the lost memories they have. Once we get fully into stage 1, now we have mild Alzheimer's disease. Forgetfulness is beyond what is seen in a normal person. They can't joke away the forgetfulness. They start having real short-term memory impairment, especially for new learning. They have difficulty recognizing what numbers mean, and they lose initiative and interest. They start becoming disoriented geographically, and they can become lost even going places they have gone many times before. They may start repeating stories or asking the same questions repeatedly because they forget. Next comes stage 2, which is mild to moderate Alzheimer's disease. The person starts having progressive memory losses, and they start having declines in their activity of daily living, social withdrawal, wandering, loss of remote memory, and they start losing the ability to recognize close family or friends. They may become agitated and confused and have memory impairment. They have sleep disturbances, and they may have delusions and hallucinations. This is usually when most people end up in a memory care home because it's just too much for the families to care for. Next, we have stage 3 to 4 or severe Alzheimer's disease. Right now, all family recognition disappears and the person forgets how to eat, how to swallow, how to chew. They have severe memory problems. They're unable to talk. They're incontinent of bowel and bladder, and death usually occurs due to malnutrition or infections from wounds or lack of immobility. A definitive diagnosis can only be made upon autopsy. However, a diagnosis can be made based off clinical presentation the majority of the time. It's a diagnosis of exclusion, meaning we've ruled out all other causes of the issues the person's experiencing, and all we have left is Alzheimer's disease. A CAT scan or MRI may show brain atrophy and enlarged ventricles in later stages, but these changes can occur in people without Alzheimer's disease. There's no lab test, no imaging study, no genetic test that can be done to say, yes, you have Alzheimer's disease for sure. It doesn't exist yet. Unfortunately, there is no cure nor any treatment that can slow the progression of Alzheimer's disease. There are medications we can try that in theory should help slow the progression, but recent research shows that they may not be as helpful as we thought. The best things we can do for Alzheimer's disease is try medication in combination with cognitive therapy and behavioral therapy, along with physical and occupational therapy to try to keep behaviors and activities of daily living as successful as possible. We also need to provide a lot of caregiver support, the same that we discussed for dementia a few slides ago. There are 4 common medications used to help slow the progression of Alzheimer's disease, but none of them will stop the progression. Donazepam or Aricept is used to manage mild to moderate to severe Alzheimer's disease by preventing the breakdown of acetylcholine in the brain. Remember that acetylcholine carries impulse or messages across nerve synapses. If the breakdown is slowed, it should allow more time for the message to transmit across the nerve. It does have side effects of nausea, vomiting, and diarrhea. Galantamine or Razidine is used to treat mild to moderate Alzheimer's disease by preventing the breakdown of acetylcholine in the brain, and also stimulates nicotinic receptors to release more acetylcholine in the brain. It does have side effects of nausea, vomiting, diarrhea, but also loss of appetite and weight loss, which is also a symptom of severe Alzheimer's. So we don't always know if it's a medication or if they're getting worse. So we don't use it for anything over moderate Alzheimer's disease. Memantine or Namenda is used to treat moderate to severe Alzheimer's disease by blocking toxic effects of excess glutamine, which can further damage brain cells. It does have side effect of dizziness, headaches, constipation, and confusion, which could be mistaken as progression of the Alzheimer's disease. Or it could be that it hides the actual progression of the disease because providers think it's just side effects. Rivastigmine Exelon is used for the management of mild to moderate Alzheimer's by preventing the breakdown of acetylcholine and butyrylcholine in the brain. It does have side effects of nausea, vomiting, diarrhea, also weight loss and loss of appetite, and also muscle weakness. And all of those, again, are symptoms of severe Alzheimer's disease, so we don't use it in severe Alzheimer's disease. Adjuvant treatment may include antipsychotics, antidepressants, anti-seizure drugs, especially if depression and seizures are diagnoses the person has before the Alzheimer's. SSRIs, which are another type of depression medication, may actually improve short-term cognition. The FDA does warn against using antipsychotics to control behavior problems in Alzheimer's because it can increase the risk of death. However, these drugs may be used in patients who have psychosis, such as schizophrenia, and have Alzheimer's disease. So what can we do as nurses to help manage Alzheimer's? There are many things we can do to help support the patients with Alzheimer's and dementia. Firstly, we want to support the cognitive function they currently have. Have a calm, predictable environment with memory aids and clocks and calendars to help reorient the person. There should be support and encouragement for activities of daily living and mobility to encourage as much independence as possible. The environment may need to change as the disease progresses. We need to balance how much activity we have them do with periods of rest. We need to make sure we promote physical safety with adequate lighting, supervision, handrails, adaptive equipment, and using glasses and hearing aids. If the person is prone to wandering, doors may need to be locked and guarded to prevent elopement, which is basically escaping. We want to reduce anxiety and agitation, which can be really hard. Things we can do include speaking calmly, slowly, using simple phrases, or even one word at a time. We want to speak to them by name, maintain face-to-face contact, and we don't want to refute any delusions or hallucinations they have. We can reorient it, but do not argue over whether or not what they see is really there or not. It's really there for them. We also need to adapt our verbal and nonverbal communication as the disease progresses. We also need to know what works for one patient may not work for another, because every patient is different and they may be different day by day. We need to provide and promote socialization with the staff and other patients as well as with their families. Remember, this is an incredibly hard disease on families and caregivers, and they may be grieving the loss of their loved one who is still physically here. We need to help promote adequate nutrition as long as they're eating safely. We need to monitor and assess chewing and swallowing function, and the consistency of foods may change as chewing and swallowing abilities decline. If they're desired by the family, tube feeding may be an option at the severe terminal stage, but honestly, by that point, there should have been conversations about the disease progression and how the late stage stopping eating is the sign that the end is near for the body. So really, we should be having good, clear communication about not doing tube feedings. And this is the end of part 3 with those mental status changes for the elderly.